Hello, everyone, and I'd like to welcome everyone to the ACPMP 2021 Appendicial Cancer Survivorship Symposium. I'm going to see if I can share my screen. There we go. So welcome. I think we have a whole lot to talk about. We have some great sessions. The day is broken into two parts. The combined session from all three of these comprehensive cancer centers, and then local sessions headed from each of the three universities which are leading this program. And at the very outset, again, I want to thank the ACPMP for sponsoring this very important symposium. I'm Dr. Ed Levine, coming to you from beautiful Winston-Salem in North Carolina at Wake Forest. And I'd like to start out with my first talk. We're going to be talking about this. Some of this is an introduction to where you are and what you've got. And for the appendiceal cancer patients, and I've been privileged to treat about 1,000, the most important thing I'd like to get across is that you are not alone. And while this is a rare tumor, and patients with appendiceal cancer are literally 1 in a million, you have an opportunity today, at least virtually, to meet with and interface with a whole host of other patients who are facing what you're facing today. Some of whom I know were diagnosed literally last week. Others are long-term survivors who are more than 20 years out. Also, a great welcome to all the caregivers who are helping all of our patients move forward through this challenge. Now, it's no surprise to say that appendiceal cancer is indeed a rare tumor. This gives you a rough idea of how common these tumors are and are not. So there's 250,000 lung cancers, close to 300,000 breast cancers, 150,000 colon cancers, on down the list. Pancreas cancer is somewhere in the range of 3,000 cases a year in the United States. Now, research monies are allocated by the National Institutes of Health and the National Cancer Institute based on incidence. So up until very recently, the only real source of research grants for appendiceal cancer research was the ACPMP. And I'm proud to say we have now been awarded here at Wake Forest, led by partner Dr. Votanopoulos, the first major research grant award for several millions of dollars for cancer of the appendix. This has come from the ongoing efforts from the ACPMP and others who have supported a lot of the research efforts which have gone forward to date with their philanthropy. So please keep that in mind. Now let's talk a little bit about exactly what you're facing in terms of appendiceal cancer. And first I'm going to talk about appendectomy. Most people know a little bit about appendectomy. It's hard to have somebody who doesn't know somebody who's had one. And there's close to 500,000 appendectomies performed a year in the United States. A tumor is found in those appendectomy specimens in about 1% of those cases. And these can be benign tumors, malignant tumors. There's actually a whole host, and I'll show you some of what these things can be in just a minute. Cancer of the appendix was first reported in 1903. So this is not really a new problem, but the magnitude of the problem has only been appreciated much more recently. Less than half the time, even with current CAT scanners and MRI scanners, do people expect or surgeons expect to find a tumor when they're operating on patients for cancer of the appendix. Appendiceal tumors represents no more than 0.5% of all GI malignancies. So they're almost always incidental finding. And elective appendectomy, knowing you're operating on a tumor of the appendix ahead of time, is essentially an unusual event. Frankly, I've got a practice which is hopelessly enriched in appendiceal cancer patients, and I'll do 2 or 3 such cases a year. Now, these tumors can be either benign or malignant. There's about 10,000 benign cases a year in the United States. They're slightly more common than the malignant ones. Most are incidental. And the ones that are probably going to be of most interest to us today are what we call the Lammen and Hammen tumors. Now, what the heck is that? Lammen stands for low-grade appendiceal mucinous neoplasm. And its nastier older brother is Hammen, or high-grade appendiceal mucinous neoplasm. These are pre-invasive tumors. but they have the nasty habit to progress and rupture, and they can lead to the pseudomyxoma syndromes. And I'll tell you more about that in just a minute. And there's a host of a variety of benign tumors of the appendix, which are relatively rare and don't really progress to anything, for which a simple appendectomy, just taking the appendix out, is curative. And now let's talk about the beast, which is malignant appendiceal tumors. Now, there are different types of appendiceal tumors. As rare as appendiceal cancer is, there are several different subtypes. Carcinoid is the one that used to be thought of as most common. I think the more common or more up to date is the adenocarcinomas and the appendiceal mucinous neoplasms are probably more than half of them now. And there are a whole host of descriptors that pathologists use to describe the different adenocarcinomas. There's mucinous, low grade, high grade, adenocarcinoid, manic tumors, goblet cell, signet ring, et cetera, et cetera. The pathology descriptors are confusing and they're changing. The World Health Organization recently came out with an additional, what they call fascicle on appendiceal tumors. And how pathologists are supposed to describe this has changed. Unfortunately, not all pathologists use the World Health Organization criteria. So understanding this, you need to talk to somebody who really knows what they're dealing with, to know the nuances between the different types of the appendiceal cancer. A question I'm frequently asked is, but I just had a colonoscopy. They didn't see anything. Why is that? And this is a series we put out a few years ago. And what we found is that we looked at all the patients who came in with advanced appendiceal cancer. Of 191 patients we looked at, about a third of them had preoperative colonoscopy within a few months, and only 3% of those cases were discovered by colonoscopy, 3%. And it's because the appendix tends to hang off of the side of the colon, and the colonoscopists or the GI doctors who are doing this have a hard time seeing it. I don't think it's a failure of the GI doctors as much as a failure of the technology. The other issue is that close to 40% of these patients had additional polyps found in the colon. And what that tells you is if you have one of these tumors found at the time of an appendectomy, before you have definitive surgery, it's important to have a colonoscopy because there's a reasonable chance there could be something else going on in the colon at the same time, a second primary tumor. Now, I'm going to show you some pictures. So if you have younger, more sensitive viewers in the audience, close your eyes at this point, at least for a minute. And I'm going to talk a little bit about pseudomyxoma. What the heck is it? You'll hear about that a lot. This is an entity which was described in 1884. And although it has a number of different monikers, what it really is mucinous ascites. Ascites is fluid in the abdomen. Mucinous ascites is mucinous fluid in the abdomen. The vast majority of these come from the appendix. They can come from other sources occasionally. Occasionally we'll see them from the ovary, rarely from the cecum, occasionally from unusual pancreatic tumors or other rare tumors, but the vast majority are really going to come from appendiceal tumors. And they're called pseudomyxoma or false mucin, which is actually not a good name because it is a true mucin. It's just not what they thought of. These tend to be low grade, but they are not all low grade. These can come from low grade or high grade tumors. And unfortunately, the 5-year survival rate left untreated is poor, only about 10%. Now, taking the mucin out can be very helpful. It can substantially diminish symptoms for a while, but removing the mucin is never curative. What you want to remove is the tumor cells that are producing that mucin. That's the trick. Now, these appendiceal tumors are increasing in incidence. You've got two studies here, and both showing exactly the same thing. So between 1970 and 2010, this has increased 2.5-fold in terms of the number of cases found, and much of this was in after the turn of the century. Now, why that is, it's not clear. I think pathologists, to some measure, are doing a better job at diagnosing. I think a lot of these were misdiagnosed as other types of tumors in the past. but this is becoming a more common entity than it used to be, rare as it is. Now, I'm only going to talk briefly about carcinoid tumors. This is about 40% of all carcinoids come in the appendix. You can get carcinoids anywhere in the GI tract and actually in the lungs as well. Most of them are in the distal tip, which means they rarely cause obstruction. There are tumor markers or blood tests which can be helpful, which are not as helpful for other tumor types. They're commonly associated with second primary tumors, and the prognosis is clearly related to size. Of note, carcinoid tumors never lead to the pseudomyxoma syndromes. Never. They do not make mucin. Now, these patients are, even if the tumor spreads, good candidates for cytoreductive surgery, but HIPEC is much less effective than it is for other tumor types. And there's recently been some substantial improvements in the systemic therapy for this. And I'm not really going to talk anymore about carcinoid tumors. The real focus are the appendiceal tumors. And most patients like to know, well, is there anybody famous who's had this disease before? And here's a couple of people that are, and this is two of the most famous ones, I think. One first is Audrey Hepburn, who got this at age, I think, 63, and Stuart Scott, who died at age 50. Stuart Scott was a sportscaster who's got actually a great quote that I hope you can see on the right lower quadrant of your screen there. If there's any surgeons in the audience, let's say if you find an adenocarcinoma of the appendix, please document what you see. Look around, but you do not have to do definitive tumor resections at that time. Patients are usually not consented for it because you usually find this at the time of an appendectomy. Biopsy it, take out the appendix if it's perforated or you have to, and then get the patient to an experienced center is what needs to happen. Again, we talked about the variety of histologies, which this can be, and unfortunately, when appendiceal cancer is found, it is usually found in a metastatic state with tumor which is spread through the peritoneal cavity. So 2,500, 3,000 cases a year of these mucinous appendiceal tumors. They're usually found ruptured. Again, second primaries are common from the data I showed you previously. There are blood tests which are useful. CEA levels, CEA 19-9, CEA-125. Now, those are tumor marks. CEA is used for any GI tumor. CEA 19-9 is a foregut cancer, usually for esophagus and gastric and pancreas cancers. Also useful for these tumors for peritoneal metastasis. CA-125 is classically an ovarian cancer marker, also used for patients with appendiceal cancer once it's spread to the peritoneal cavity. Now, on the horizon are liquid biopsies. You're going to be hearing more about that later in an upcoming talk later in the morning. I don't want to talk about that, but that's clearly got some potential for patients with cancer of the appendix. For patients with adenocarcinoma of the appendix, the prognosis is clearly very closely associated with grade. The risk of nodal disease is very closely related to grade, and the prognosis, even if the tumor has spread to the peritoneal surfaces, is also related to the nodal status. So you want to know if the tumor is spread to the lymph nodes and for the higher grade tumors. Beware the several pathologic descriptors. Signet ring cell, aggressive, poorly differentiated, goblet cell, adenocarcinoma. You can see all these terms thrown around. Most pathologists are going to see one or two of these in a year. Unless you're coming to a specialized center where you see a lot of these, or you have an experienced pathologist review the specimen that was removed at the time of any surgery, you can be misled a little bit. In general, if the tumor is high grade, we usually add a right colectomy. If it's low grade and the margins are negative, we just take out the appendix. You don't necessarily always have to remove the right colon for the low grade tumors. Frankly, if the tumor is unruptured in the appendix and the margins are negative, a simple appendectomy is curative. We just did a study, and this was a paper that came out a few weeks ago, quite frankly, looking at the operative reports for general surgeons who do appendectomies. We looked at 490 reports for cases that we had treated here at Wake Forest, all of whom were incidental. So all the patients were operated on for what they thought was appendicitis. And while 80% met the technical requirements for reporting an operative report, 44% made no comments at all about whether there was anything in the peritoneum. Now, these are patients who have got widespread peritoneal metastasis. 48% had only a partial view, and only a handful, 7%, had a complete evaluation where they actually turned the scope when they're doing, and most of these are done laparoscopically nowadays, around to survey the rest of the abdomen to see where the tumor is and isn't. And this has led us to embark on an education effort for general surgeons to help them document, because it's going to make a large difference to future appendiceal cancer patients to know exactly where the tumor is and isn't, to avoid repeat laparoscopic explorations, unwarranted things. And the other thing we found is that 15 to 30% of the pathology reports were not correct when compared to the final reports. And a lot of this is related to pathologists who are not used to seeing this type of unusual tumor, generating some reports which make misclassify something as low grade as to high grade as to low grade, et cetera, all of which has substantial impact on the treatment plan for the patients. So let's talk a little bit about grading, because for appendiceal cancer, these mucinous tumors, the histologic grade is really important. The original descriptor of this was written by Dr. Ranette, who was a pathologist at Johns Hopkins who worked with Dr. Sugarbaker, and she came up with a 3-tier system. Here at Wake Forest, the Memorial Sloan Kettering, several other places use a 2-tier system, low grade versus high grade. The worst actors are signet ring and goblet cell cancers. Now, signet rings, you have to be careful. There are specific rules for what percentage of the tumor has to have signet rings in it. I've seen many patients labeled as signet ring when a pathologist says, well, potential suggestive signs of signet ring features. If they're not definitive signet rings in significant numbers, that doesn't qualify as a signet ring cancer, and the prognosis is difficult. As I said before, there is a WHO, that's World Health Organization, and a fascicle is basically a pamphlet in terms of how these things should be agreed to. This was agreed by the World Health Organization, which is supported by the United Nations, of all things. Having said that, not all pathologists subscribe to it or use it, which leads to all sorts of confusing descriptors and changing rules. Now, the bad news is the older literature you read, the worse and more complicated this becomes, because it was the fascicles before were even worse, and there was less adherence to rules for dealing with things. Now, I'm just going to show you some pictures of what these cells look like under the microscope. What you see here is a low-grade tumor. So on the right side of your screen, that's mucin. At the edge of what looks like the whitish area, there are a handful of cells. I'm going to see if I can point to this with the pointer right here. I hope you can see the pointer at home. Those are the cells. That little amount of cells, that's what's producing all the mucin. And those cells are producing underneath them, this is all sclerotic fibrous tissue. So around these handful of cells is a large fibrous sclerotic core. The actual tumors, if you see them, are not soft and mushy like mucin. They're actually hard as leather. But you're seeing just a handful of cells causing a great deal of trouble. And that leads to some of the problems with some patients having no cells seen in large mucin pools. That doesn't mean they're being produced by nothing. That just means you didn't find this small number of cells which are producing the problem. This is more of an intermediate grade, and you're seeing some other things here. Now the number of cells, some of these cells are infiltrating into these little cords between the mucin pools. And this whitish material here, that's what mucin looks like under the microscope. And you see a few of these cells are actually starting to break off and float away in the mucin pools. So that's what defines an intermediate grade. And this is a high-grade tumor. Again, you see more cells, which is little circular things out here, in these little cords out here in between. And now you got lots and lots of these cells. These are cancer and tumor cells floating away in the mucin to cause havoc in other places. And that's what the pathologists are looking for when they classify these tumors. Why is this important? What you see on the screen is 3 different survival curves from 3 different organizations looking at histologic grade and outcome. And for each one of them, and these are somewhere between 5 and 15, 20-year survival rates, G1 is low grade, G2 is high grade, G3 is very high grade for those that you'll see. And you can see the differences in survival. Most of the patients with low-grade tumors are going to be long-term survivors. And the prognosis of the intermediate grade and the high-grade tumors is substantially worse. So we can prognosticate very crisply on what the pathologist reviews. But I want to point this out again, an expert pathologic opinion in the tissue that's been removed to assign the grade is crucial because much of the therapies are going to be based on that grading. Now, not all appendiceal tumors are created equal. Even with the plethora of clinical markers, some patients still do poorly, even with relatively low-grade tumors. Now, at the top of the screen, I've listed many of the prognostic features that we see. These are a whole handful of things: grade, stage, completeness of resection score, nodal status, experience of the team, experience of the surgeon, intraperitoneal therapy, ascites, comorbidities the patients may have, et cetera, et cetera. I wanted to look beyond that, and several of the institutions have. And what I'm showing you here, the word of the day is dendrogram. And the picture on the left side of the screen is a dendrogram, which is looking at how these different tumors, each one of those little dashes on there is a specific gene. And this is the first study that I know of that was done looking at appendiceal and colon cancers, looking at the different genes that are active. So instead of just looking at the cells under the microscope, we're now picking them apart and figuring out what part of the DNA is active. And on the right side of the screen, the green line at the top, those are low-grade appendiceal tumors with favorable histology. So if the genetics are favorable, that's what you're going to get. The other ones are going to be colon cancer or high-grade appendiceal cancer, the other line. And what did we find from this very first investigation, looking at appendix cancer, is that appendix cancer is very different than colon cancer. We then did additional analysis on this. We can actually tell you what type of mutations they have. We looked at the whole, what they call whole exome sequencing, which means looking at all the DNA that the patient has in these cells. And there's close to 40,000 genes in the human genome. So this is a whole lot of DNA sequencing. And this is again, a complicated map. I don't expect you to be able to read this. We have a list of some of the most common mutations here. And these are the different types of mutations. And those are things that you have a DNA base has been replaced. The DNA base is missing. There's a code in the DNA code which tells the DNA to stop making proteins, start making proteins in the sequence. So we know a whole lot about what the mutations are. And it also tells you that the number of mutations that we have here tends to be very low. And I'll tell you why that's important in just a minute. And that was work that was done here at Wake Forest. Other centers have done sort of the same thing. There's two large houses which do what they call precision medicine or next generation sequencing. And this is a series of 700 patients who had next generation sequencing. That looks at several hundred genes, not all the genes. And what did they find? The most common genes that are mutated are two called KRAS and GNAS. There's some other ones which are somewhat prognostic. And what did they find? They found that the mutation profiles of appendix cancer are different than colon cancer. This is a very similar study of a smaller number of patients. And in this study, they had 224 patients with appendiceal cancer. And what did they find? The total mutation burden is low. Microsatellite instability is low, and those are important to predict who's going to respond to some of the newer checkpoint inhibitors. And the mutation profiles are, again, very different from the colon cancers. Now, that's important because in what you see at the bottom is an next generation sequencing report that we got from one of my patients. And it basically, what it says is there's no mutational burden in here, and there are no targets. And unfortunately, that is what most patients with appendiceal cancer are going to get when they get these next generation sequencing reports. That doesn't mean they're not worth to do them. What it does mean is that very few of these patients, less than 5%, are going to have an actionable mutation. From all this genomics, what have we learned so far? Appendix cancer is not the same as colon cancer. And that's important because all the chemotherapy for appendix cancer is based upon colon cancer. And that is unfounded. Genomics are clearly here to stay. You're going to be hearing more and more about these, again, later in the talk. So what are your options for treatment? Chemotherapy, immunotherapy, which unfortunately is rarely useful. Radiation therapy, I'm going to tell you not to do that. People have tried shunts to try to shunt the mucin out of anywhere. Definitely don't do that. Conventional surgery, cytoreductive surgery, and HIPEC. And for some patients who aren't candidate for any of that, there's always palliative care and hospice. That's not something we like to resort to. Now, the chemotherapy response rate, and this is a study which was done with us at Wake Forest and MD Anderson years ago, the actual response rate was only 8% to conventional chemotherapy. So these tumors aren't super responsive to chemotherapy. Now, some of the high-grade ones are. The systemic therapy progression-free survival was better for high-grade tumors. Overall survival was better for high-grade tumors if you did get some chemotherapy, not statistically significant. But systemic chemotherapy is not curative of this disease. I don't know of a single case that's clearly been cured with chemotherapy, although as the chemotherapy gets better, that's going to happen sooner or later. They're best for high grade. They have extremely limited utility for low grade. And for patients with pseudomyxoma, stable disease is the goal of treatment, not to have the tumor shrink. Now, cytoreductive surgery and HIPEC is something I believe almost everybody tuned into this is going to be familiar with. The goal is to remove, you have a disease where there's got extensive peritoneal metastasis, and we want to use aggressive peritoneal therapy. This is delivering chemotherapy into a field with the abdomen opened up and all the scars and adhesions taken down after the tumor has been removed. So the HIPEC is delivered typically after all the surgery has been done. This can avoid what they call epic or additional ports for intraperitoneal chemotherapy given in the postoperative period. It's usually delivered with some moderate hyperthermia, which helps the chemo work better. And you have a phenomenal advantage in terms of getting the amount of tumor. You can literally pour the chemotherapy on residual cancer cells rather than diluting it through the entire blood volume by giving it systemically. The selection criteria, what you see here, you want to have a resectable primary, resectable metastasis. We like to avoid extra-abdominal disease, and the patients have to be fit for a big operation. That includes cardiopulmonary, nutritional performance status, and more recently, from some of the other research we've done, a lot of emotional and support for these patients. Patients have to be well prepared for these operations. The better prepared you are when you go in for these procedures, the more likely you are to come out the other side doing well. And these are what we use. We do screening. This year, we're doing routine COVID screening, of course. We screen patients for MRSA, which is a bacteria in resistant staph. We make liberal use of vaccinations for anticipation of splenectomy and a lot of psychosocial support for our patients. How do you do this operation? The operation is done with the goal of complete removal of all the disease. The goal of these cytoreductive surgeries is not to take out the easy stuff, but to get everything cleared out if possible, and then to deliver the chemo perfusion in a uniform fashion. Here we use a 2-hour perfusion. Some centers use 60 to 90 minutes. And again, this is the advantage you get from delivering the chemotherapy into the peritoneum versus intravenously. So that's a peritoneal plasma ratio. You may have heard of the blood-brain barrier. There's also a plasma-peritoneal barrier. So delivering the drugs we usually use for appendiceal cancer, mitomycin and oxaliplatinum, is giving somewhere between a 25 and 75 to 1 advantage in terms of delivering drug to target. You may have heard of the PCI, or peritoneal cancer index. This is a measure of how much tumor is in the abdomen. So after we open up or we put a laparoscope in to assess things, we want to see how much is there. We divide the abdomen into 13 zones. Each one is scored 0 to 3. So the scores go between 0 and 39. After we know that, we want to know after we do the operation, we want to know how much is left once we get it done. And this is what they call the completion of cytoreduction score. You might hear a CC score, completion of cytoreduction score. We use an R score, which stands for residual, which comes out of the staging manual for tumors. And basically, you want a CC0 or an R0 or R1, and that just means there's no gross residual left. CC1 is the same as R2A, essentially, and those are CT2 and 3 means there's more residual disease left after maximum effort at cytoreduction. And you can use these for prognostication. Again, this is a picture of what one of these perforated tumors looks like. This is our experience at Wake Forest of 949 patients that we've operated on for this as of this week over the course of about 30 years. And this is what shows you what the prognosis looks like. So the top lines are for patients who had complete cytoreduction on the left. It also shows the lower numbers. You have a curve there, which is low grade versus high grade, with or without nodal metastases. And we can prognosticate pretty crisply in terms of how you're doing. And also know these are not 5-year survival rates, but we're talking about 10-year survival rates and beyond in the 70+% range if a complete cytoreduction can be achieved. Now, this is a score of what kind of shape is the patient in when they get here to see us. The 0 or 1 means the patient's 0 is in good shape, 1 is minimum symptom. By the time you have significant symptoms, which is called an ECOG-2 status, your prognosis is substantially worse. And for patients who are seriously symptomatic because of the bulky disease, their prognosis is much worse. So we want to get to patients before they're having massive symptoms. The time to come in for this is not when you have trouble eating or with a bowel obstruction. Now, this is a series of the first 1,000 cases we did here at Wake Forest. And what you see here is the 5-year survival rate broken by quintiles or 5 parts. The bottom line is the experience with the first 200 cases we did. And I say that because you want to go to an experienced center, which has a lot of experience with this, because the survival gets better as you go to a more experienced center, significantly better. But what have we learned? These are the key prognostic features for cancer of the appendix: histologic grade, peritoneal cancer index, how much disease is there, how completely was the resection done, what kind of shape are you in, or the nodes, and again, where is the centers on the learning curves. Now, there's only been really a couple of prospective randomized trials. There was one in the surgery branch of the National Cancer Institute, which was a prospective randomized trial, which wanted to compare cytorectal surgery with or without HIPEC. And at the National Cancer Institute, where they gave their surgery away for free, they couldn't get the plane off the ground. Unfortunately, they couldn't accrue to this trial, which would have answered an interesting question. There's only been one prospective randomized trial for cancer of the appendix, and I'm proud to say I ran it here at Wake Forest with the assistance of my associates at MD Anderson and the University of Pittsburgh. This is a prospective randomized trial. 133 patients were accrued. And this is a straightforward trial looking at patients with appendiceal cancer with peritoneal dissemination, and we randomized patients to using either mitomycin or oxaliplatin in the perfusate. It took us 6 years to accrue this trial. This was not an easy one to do, and this was not supported by National Cancer Institute funds. This was supported by philanthropy, which is why I'm going to continue to ask everyone on this session to please consider supporting ACPMP and your other regional centers which are doing research for this disease. What did we find for this? There's a difference in terms of what the white counts are, and it turns out that the mitomycin is harder on your white count than the oxaliplatin. The oxaliplatin is a little harder on your platelet count, though not significantly so. But what did we see in terms of overall survival? These are the 2 lines. No difference in overall survival, no difference in progression-free survival in this randomized trial, which is the best data you can get. And again, if you have low-grade tumor, which is the top lines here, you do a whole lot better. Over 90% of the patients are still alive, doing well 5 years later with these low-grade tumors who undergo the HIPEC procedure with a complete cytoreduction. But whether you had oxaliplatin or mitomycin didn't seem to make a difference. We did find a slight difference. This is an index of quality of life. Over the first 6 months or so, patients had a slightly better quality of life if you used oxaliplatin rather than the mitomycin. So what do we conclude for this? Most importantly, trials for cancer of the appendix are certainly possible. There's some differences in white count and platelet toxicity. Quality of life is slightly better with the oxaliplatin, which is why I use as the default agent here. And they have relatively similar efficacy. We also looked at quality of life, and I'm going to go through this relatively quickly. And I'm going to get to this. These are timelines. On the left is baseline, 1 month, 3 months, 6 months, 12 months. It takes a good month just to have slightly increased pain scores for a month, and then it tends to go down from where it was. So these are big operations to get over. This is my favorite slide in this whole slide deck. And what you're seeing on the left is markers of depression. And a lot of the patients come to us with depressive issues. You'll hear more about this in some of the talks later. And for those depressive symptoms, if you have a HIPEC, by the time you get to 6 months, the risk of major depression is cut by about 50%. That makes going through a HIPEC a better antidepressant than Paxil or Zoloft. So we've learned a lot from quality of life. We've learned that sleep disturbances are a problem, and we can maintain long-term quality of life. Depression is found in a lot of patients, and we screen for that routinely. We also looked at the quality of life for the caregivers of patients. This is a patient study we published last year. We'll hear from Dr. Duckworth later in the morning, who's my co-author on this. We found a number of things. Interestingly, if you look at the depressive scores for the caregivers, it's worse than the patients. Patients going through it are a whole lot tougher, and we've also found the financial worries are not quickly resolved. Those go on for some time. We ask a lot of our caregivers, And for the caregivers who are on this session, thank you, and we support you. We salute you for being there for our patients. We do a lot of research here. We're going to ask everyone, you'll hear a lot about research from some of the other centers. We look at HIPEC databases. We have a very large tumor data set. You hear more about organoids, for which we received a prestigious R01 grant. You'll hear from Dr. Botanopoulos a little bit later. We're looking at phase 1 agents and genomic studies, quality of life for patients and family members. And before the sun sets, what am I going to leave you with? This is a rare disease. You know that already if you're on this session. It's increasing in incidence. The grade and resection status are the key prognostic indicators. Experience, where you get your treatment done by the surgeon, by the pathologist, by the whole team is important. Morbidity and stoma rates, there's some complications. It takes a while. Long-term survival is clearly possible for a large percentage of our patients. Genomics are improving things, and we are extrapolating chemotherapy from colon cancer is unfounded. Appendiceal cancer is not the same as colon cancer. So on behalf of our HIPEC team, and we are celebrating our 30th anniversary of our HIPEC program here at Wake Forest this year, I'd like to thank everyone for joining us. And I'd also like to thank everyone at ACPMP for giving me the privilege of speaking with you this morning. Thank you.